Welcome to AETCM, the emergency medicine channel.
Yes.
Shall we start?
Yes.
84-year-old female with no known comorbidities presented to ER with complaints of deviation of angle of mouth to right since 2 days after waking up from sleep. On initial 10-second assessment, airway is patent, no pooling of secretions, breathing, respiratory rate is 16 per minute, saturation 98% in room air, air entry bilaterally equal, circulation BP is 160 bar 80 millimeters of mercury, pulse rate 80 per minute, all peripheral pulses equally felt bilaterally. Coming to disability, GCS is 15 by 15, pupils 2 millimeters bilaterally equal and reacting to light. Coming to exposure, temperature is 98.6 degree Fahrenheit, GRBS is 100 milligram per deciliter. Coming to history, 84-year-old female with no known comorbidities presented to ER with complaints of deviation of angle of mouth to right side since 2 days after waking up from sleep. There is no history of any one-sided weakness, altered mental status, headache or fever. Patient had complaints of left-sided external ear pain since 2 days, but there is no history of any ear discharge or vesicles. On examination, patient is conscious oriented, no pallor, icterus, cyanosis, clubbing, lymphadenopathy or edema. Coming to CNS examination, there was no wrinkling of forehead on the left side. Patient was unable to close the left eye completely. Deviation of angle of mouth to right side. Power in all limbs are 5 by 5. Sensations intact. Cerebellar signs negative. And other systems are within normal limit. So coming to diagnosis of left element facial palsy.
Okay. Why you told it is element facial palsy?
Because one side completely hemifacial weakness is there. No wrinkling of the from the upper part and lower part both sides the weakness is there.
Upper and lower part of the face is involved. So you think that it is element. Can you get upper part of the face involvement in UMN palsy?
No, upper part is spared in UMN.
That is MBBS knowledge. MBBS knowledge is correct. Upper part is spared in UMN palsy. It is due to
bilateral supplies there from
50% of the supply of the right side is by left side and 50% is by right side. Okay. In a case of severe weakness, it's only a relative sparing of the upper part. So if you read the books, you can clearly know it is only a relative sparing of the upper part. It is not complete sparing. So in a severe weakness, even upper part of the face also can be involved, even in UMN type of lesion. But that will be relative sparing, means some amount of weakness will be there, but sometimes weakness will be completely, there will not be any weakness at all. That's why it is written that it is a relative sparing of the upper part of the face. But here in the element type of facial palsy, it is completely gone. Okay. What is Bell's sign?
When we try to close the eyelid, we can see the uprolling of the eyeball.
Is it a normal phenomenon?
Normal phenomenon, but usually we can't see.
Okay, we will not be seeing. So here we are seeing. That's why
it's
that Bell's phenomenon is seen in element type of facial palsy. Okay. What is the reason for this condition now at present in your patient? What is the reason for that?
Can be any herpes.
Herpes.
Any viral.
Huh? Reactivation of? Here, there is no lesions.
Vesicles are not there.
Vesicles are not there. Okay. Ramsay syndrome is a reactivation of herpes, and that produces weakness with vesicles. Okay. Here also it is a herpes virus only. Infection is due to that, but it's a primary infection of the nerve. Okay. How do you know that central part of the brain, CNS, is not involved? What are the features of CNS involvement in facial nerve palsy? Different type of features. Facial nerve can be involved in UMN type of palsy and element type of palsy. Here, since you are telling it's a Bell's palsy, only element lesion. What are different types of facial palsies where all lesions can occur?
If in the precentral gyrus, it is UMN, the contralateral lower side of the face will be affected.
Okay.
And if it is in pons or around the pons, there will be hemiplegia will be there.
Hemiplegia on opposite side and opposite side facial weakness. It's all same. Okay, then
if it is element, there will be.
So in pons itself, different areas are there. Pons or midbrain, pons, medulla. Medulla it will not be involved. Midbrain and pons also it can be involved. How do they differ?
Other cranial nerve also affected in
If it is spontaneous infarct, you can get spontaneous infarct. You can definitely have one side weakness. How do it differ from the UMN lesion of the internal capsule or
Crossed hemiplegia.
what is crossed hemiplegia?
That is facial nerve palsy in the ipsilateral side and weakness on the contralateral side.
Opposite side. Okay. So that is spontaneous lesion. Okay. Now any sensory involvement can be there in facial nerve involvement.
Try and yeah, pinna.
You tell me.
Sensation of the pinna can be involved.
Then
sensation and
what special tongue?
A special
Okay.
sensation.
Taste can be involved
do
in
that.
element type of. So can you do that in emergency room? It is not possible. For us it is not important also, but it can be involved. Okay. This patient has got any tinnitus, vertigo?
No
Nothing.
other ear symptoms, no discharge or nothing. Only this ear pain was there on external. This pinna area there was yeah.
Okay.
She was.
So what is this condition? This Bell's palsy means what?
Element facial.
No, what that means what? Element facial palsy can be due to so many reasons. What is the mechanism here?
Idiopathic.
Basically, it was known as idiopathic facial palsy. It is due to the inflammation of the facial nerve in the canal. Okay. Now it is known that it is due to the virus. Okay, herpes virus. Okay. So how do you treat this patient? What are the basic treatment you have to? Should we do an CT or MRI in this patient? Is it recommended? As an emergency physician, you should know because this is a MBBS case. Everyone know that it is Bell's palsy. As a ER physician, you should know two things: how do you treat the patient? What investigation you do for this patient? Will you do an MRI, CT scan for this patient? Is it recommended? Is it necessary?
If it is clear-cut element facial palsy, there is no need.
You tell me clear-cut answer. Should we do MRI or not?
If there are no other focal neurological deficits.
I am asking this patient, should we ask for an MRI or not? There are guidelines, NHS guidelines. In our country it is not there, but according to guidelines, whether it is recommended or not. Bell's palsy, MRI is recommended or not. You know that it's a clear-cut case of Bell's palsy. Is it recommended or not? You have to tell me.
Not recommended.
It is not recommended. If you clinically, if you know that it's only a Bell's palsy, there are no other cranial nerves involved, there are no lesions in the ear canal, there are no long tract signs, there is no need of any type of imaging modalities. But if the patient want to do, then you can go ahead with and do the MRI. Okay. So ideally, there is no investigation recommended. Then
First, the eye.
how do you manage the case?
First, we should see the eye that is the Bell's phenomenon is there or not. If there is the
Patient
eye
is
care,
unable to close the eyelids. So what you do?
Padding can be.
Padding should be done, and you can give even glass, protective glass can be given, spectacles can be given. Then
IV steroids should be started as soon as possible.
okay, why steroids are recommended here?
Was to decrease the edema around the nerve canal so that
Okay, to reduce the size of the nerve, otherwise nerve will be permanently destroyed. Steroid should be given as fast as possible. Then
antivirals can be started.
which antiviral you routinely give?
Valcyclovir.
Valcyclovir or
acyclovir.
acyclovir or valcyclovir or famciclovir, anything can be given. Acyclovir, what is the dose?
Acyclovir for 400 milligram.
800 milligram 5 times daily. Okay. Valcyclovir
1 gram.
1 gram TID. Famciclovir it's 500 milligram TID. Okay, so doses are slightly different, but almost similar effects can be there. Okay, what else you have to give for this patient? Physiotherapy, nerve stimulation. So that should be advised. Nerve stimulation should be advised, and movements of the face should be advised. That should be done only by physiotherapist. Okay. How do you differentiate element facial palsy from human facial palsy? This is all MBBS based basic questions. I am not asking anything high. As a ER physician, you should know whether to do a CT or MRI in this patient. When to do a CT or MRI, that is very important. Second thing, you should start the treatment as fast as possible. No need to wait for anyone. You can just start steroids with acyclovir. Only if the patient is diabetic, then you should be very careful in starting steroids. Okay. So how do you differentiate LM and facial palsy from UM and facial palsy?
As clinically, we can differentiate with hemifacial weakness and
One-sided weakness with one-sided complete weakness is mostly LM and facial palsy.
then if there are associated any weakness of the body.
Okay. That is UM and facial palsy. Okay. Where will you get bilateral LM and facial palsy? Will you get any condition bilateral LM and facial palsy?
Crate, snake bite.
Snake bite. Okay, snake bite can be like cobra or cobra or crate bite. You can get bilateral facial palsy, but that's a part of general weakness. Where else you get? Huh? Bilateral LMN type of facial palsy.
Multiple sclerosis.
Multiple sclerosis, not very common. It can occur. If it is occurring in the bones, you can get. But sarcoidosis is one condition where you get bilateral LMN type of facial palsy. How do you differentiate bilateral LMN facial palsy from bilateral UMN facial palsy? I am only asking BPS questions.
Emotions will be
Emotions will be?
preserved in element.
Emotions will be?
Preserved in element.
Emotions will be preserved. That means patient can express emotions in a bilateral LMN facial palsy. It is the other way. Emotions are spared in UMN facial palsy because the centers are totally different. Whereas LMN facial palsy, final common pathway is affected on both sides. So patient cannot produce any emotions even if they can, but the face is not moving. Okay, so that is a problem. What is mimic palsy? Mimic palsy, medicine PG should be knowing all these things. You need to know. Mimic palsy. It mimics bilateral LMN facial palsy. Even emotions are not there. Parkinsonism. Parkinsonism is known as mimic palsy. Okay. So what else you want to tell?
The management can be actually with acute Barrett's palsy, we can divide into two. Let's evaluate the eye closure and the grade degree of facial weakness. By evaluating the eye closure, if it is adequate eye closure, no eye protection is required. If it is inadequate, implement any eye protection measures. And the degree of facial weakness, if there is, we can divide with House-Blackman grading, with mild to moderate and severe to complete. Both we will start early treatment with oral glucocorticoids, and if it is severe to complete, we can give valcyclovir 1 gram.
Is there any difference between oral and IV steroids?
Oral bioavailability.
Bioavailability is same. So either oral or IV can be given.
Then after the
So what dose you give for this patient?
prednisolone can be given 60 to 80 milligram.
What is it per kg body weight?
1 to 2
milligram per kg. Okay.
Then after follow-up evaluations, if it is complete recovery, it is well fine. If it is in incomplete recovery, we can consider botulinum toxin injection for synkinesis, facial spasms, hyperlacrimation and cosmetic appearance. And if it is slow progression of weakness beyond 3 weeks or no improvement at 4 months, neuroimaging can be given to exclude any malignancies.
Okay. So any other demyelinating condition other than multiple sclerosis you have told can present with facial nerve palsy? You have to tell me. What are the conditions where you get descending paralysis? Ascending paralysis is GBS. Where all you get descending paralysis, that means cranial nerves will be involved. In that basically bilateral facial nerves are the first one which is visible to the doctor. Descending paralysis. Ascending paralysis is GBS. Descending paralysis means the first facial nerves are involved. Then patient will have difficulty in breathing. Then patient will have myasthenia. Is by evening they develop weakness. That can occur. Botulism. Botulism is one condition. Then, you should know all these things. What else? Tick paralysis. Not very common in our state. It is very common in Karnataka and all. Okay. Then, some areas of Karnataka. Okay, not in all areas. Then, one variant of GBS. What is that? Miller-Fisher variant. What is Miller-Fisher variant? Same thing, facial nerve palsy, ophthalmoplegia, then patient develops descending paralysis. So these three, four conditions you should remember. One is botulism, not very common in our country. It is very common in which country? Which Asian country it is common? China, Japan. It is very common there. Now we are also going to get, because tin, that container based food is available here also. Okay. So botulism, tick paralysis, Miller-Fisher variant, then like you told, bites, snake bites. There the first evidence will be drooping of the eyelids, then facial nerve palsy, then difficulty in breathing, all these things come. Okay. Anything else you want to add? So this is basically a case of element type of facial palsy without any reason. That is mostly Bell's palsy, or previously it was known as idiopathic. Now we know that it's a viral induced. So treatment will be basically steroids with antivirals. And physiotherapy has got a major role. How many days it will take to recover? Patient will ask you. Normally how many days it will take to recover?
6 weeks.
Normally by 2 weeks they will have complete recovery, but it can take up to 6 months. Okay, some patients may take longer duration. Otherwise, normally they come back, they recover within 2 weeks. Okay, thank you.